Thank you.
This meeting is being recorded.
Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Morse is representing Dr. Ashwin Basan in a voting capacity. Next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on January 10, 2022. Anybody second it?
Second.
Thank you. Let me call each one of the members for the vote. Jose?
Yes.
Dr. Katz?
Yes.
Sally?
Yes.
Frida?
Yes.
Dr. Morse? Oh, Dr. Morse is not in yet. Okay. We can call for her vote after she joins. Next is a diversity and inclusion update from Iveles Mendez Justiniano.
I'm sorry, Penny, before you move on, please poll Dr. Martone.
Oh, Dr. Martone, sorry. Dr. Martone?
Yes. Hello.
Hi, do you vote okay for the meeting minutes from last meeting?
Yes.
Okay, thank you. Sorry about that. So the motion is carried. The agenda, the meeting minutes from last meeting, January 10th, 2022 is adopted. So next is a diversity and inclusion update from Iveles Mendez Justiniano.
Good morning, everyone. So the updates will be provided broken down by our different areas of concentration within the Diversity and Inclusion Office. We'll start off with our language access section, in which 88 staff completed the first medical interpreter skills training, which we call MIS for short, and we were focused primarily on the Spanish language. We are looking to expand those languages in later years. We also selected 4 new vendors to provide training on diversity. This includes unconscious bias and various other areas as needed, so we will be able to expand our training capacity. We've met with the Mayor's Office of Immigrant Affairs and a community-based organization to discuss language access services at Elmhurst and all the different services that are provided there. In addition to that, we fulfilled 250,000 interpreter requests, which equals 3.6 million minutes. And the top languages that were requested as far as interpreter services were Spanish, Bengali, and Mandarin. As far as EPIC, we also added simplified Chinese as a language option in our electronic medical record. And then we had 687 documents which were translated. The top languages were Spanish, Bengali, and simplified Chinese. And I will pause there for any questions on this section.
I just have a quick question on the 88 staff members that completed the first medical interpreting skills training. Are these people who, in what they do in their jobs, need to have these kind of skills, or people who are just choosing to have them as an additional skill set?
So great question. It's a combination of both. These are individuals that volunteer to complete the program. And in addition to that, if they are called upon, they can volunteer their time to serve as interpreters. But these are not individuals that their sole function will be to interpret.
Okay. Is that like then at some point when they get raises or whatever, that's included as an additional skill they possess? I mean, are there advantages?
So one of the advantages is, again, individuals that come in through the hospital system and they speak a second language, most often this is something they want to do. So we currently get asked all the time as employees are coming in, if I speak Spanish, can I interpret? To which we ultimately say no, absolutely not, until you receive the competencies and the training needed. Once they complete that training, then they will be able to serve as interpreters as needed and as time is available to them.
Okay, thank you.
Okay, moving on.
Thank you, Sally. Can you hold 1 second?
Sure.
Dr. Mars, I think you have a question. I see your hand raised.
Yeah, thanks so much. And I apologize, I was a couple minutes late, so if you already addressed this, please excuse me. But I was just curious about the language access. Does this reflect health visits in addition to in-person visits? And can you say anything about the telehealth access for language?
So I don't have it broken down for this particular report. This is the languages represented are what was requested system-wide. So whether it was telehealth, whether it was in acute, whether it was in post-acute, it gets aggregated, and the top languages within the system are Spanish, Bengali, and Mandarin. We can always go back, provide a more granular report if needed.
Thank you for that. Yeah, I would be really interested in seeing more about when it's requested for the telehealth visits and what languages.
Noted.
Thank you, Dr. Morse. Jose, any questions so far?
No questions, thank you.
Dr. Katz? Frida, any questions?
No questions. Thank you.
Dr. Marton, any questions?
No
Or
questions.
comments?
Thank you.
Okay, thank you. Yes, let's continue, Willis.
Okay, so moving on to the apprenticeship program. So this exciting new program is sponsored by District Council Number 9, Local Union 1969, and the International Union of Painters, Allied Trades as part of the New York State Department of Labor Registered Apprentice Program. What this program does is it enables H&H to provide participants with 4 years of supervised training, and it's allowing them to develop allowing us to develop a pipeline of candidates with the necessary skills and experience to successfully pass the civil service exam and be appointed to available painter vacancies throughout H&H. The program will serve to recruit a diversified population, focusing on women as apprentices, which is a non-traditional role for women. And I'll pause there. Any questions on that program?
Any questions? No?
Just
Yes,
4
let's
years of
proceed.
supervised training, is that
Oh.
the members of the union that are doing the training? When you say H&H will do the training, who's doing the training?
So it's a partnership. The training is actually being passed on by the unions. The unions are doing the training, and then we do a subsequent portion of the training as part of sexual harassment, human trafficking, anything that's needed on the H&N that's part of required training, we're doing. The role-specific training is happening on the other side.
Okay, thank you.
Thank you. Any other questions? No? We can proceed. Thank you.
Moving on to communications. So we had several system-wide communications going out to observe different celebrations. We observed Immigrant Heritage Week, and we observed Jewish American Heritage Month, of which we're actually having a specific session on May 25th commemorating Jewish American Heritage Month. We also have system-wide messages from Dr. Katz that were sent out to the entire workforce. These included observing the month of Ramadan, also a message in solidarity with the people of Ukraine, and we celebrated Black History Month with Black Health and Wellness. Shall I continue?
Yes.
Okay. Training completions. As a system, we have a completed number of 55,169 training completions. Of the individuals that completed the particular trainings, which focused on roles such as Lgbtqia, interreligious awareness, diversity and inclusion, all the different topics, the breakdown was 71% were female, 27% male, and 3% unknown. When you look at the training completions via ethnicity, we had the highest number of percentages that completed training on the diversity and inclusion topics included 32% Black or African American, 22% unknown or unreported, 18% Asian, 14% Hispanic, 13% white, and 1% American Indian. When we look at socialization of diversity and inclusion, we actually have been going out to the facilities. I have been meeting with the CEOs, with their executive leadership teams, and we're focusing on what the DNI office offers. So training that we offer, we're also looking at what does the facility need in support from the DNI office, and also to increase the awareness of DNI services and offerings throughout the system. So we're starting at the top level with the executives, with the leadership, and then we're working our way down so that we can meet the entire staff and let them know what DNI looks like at New York City Health and Hospitals. Should I continue or pause for questions there?
Yeah.
Okay. So we also have a diverse pipeline initiative. I actually sit as a co-chair of the New York City Board of Directors Career and Technical Education Council, which is part of the New York City Board of Education. This particular quarter, we participated in 3 panel sessions, which were held for students and teachers at underserved schools and focused on careers in healthcare. So we had nursing participate, we had behavioral health participate, and what these panel sessions did is provide an opportunity for students who may be graduating from high school and maybe not going into college, or even those students that are going into college, provided them with areas that they could focus on that were of high need at New York City Health and Hospitals. So these included behavioral health and nursing and PCTs. In addition to that, we also serve as advisor. So we look at the current healthcare trends, look at what is needed and what will be needed at New York City Health and Hospitals, bring that to the New York City Board of Ed, specifically for students that are interested in healthcare, and make the information available to them. We've also held recruitment events for students of diverse backgrounds to participate in healthcare settings. So we have partnerships with different schools throughout New York City. These include CUNY, almost all the schools in CUNY, NYU, Sophie Davis, and multiple colleges for pharmacy students. And what we do is we actually go out to the schools, we hold fairs, we let them know who we are, what positions we have, and then we bring the students in to work at a variety of healthcare settings, which include the acute cares, post-acute. At this point, no, take that back, not post-acute due to COVID, but we're focusing on the acute sites. And so this is an ongoing thing which we have, which actually promotes diversity in healthcare for all different roles. Promoting diversity in healthcare then also leads to our mentoring program. So we have phase 1, which we launched in May of 2021, which primarily focused on certifying mentors or individuals that were interested in becoming mentors throughout the system. We had a total of 67 mentors who completed the training. When you look at the gender breakdown, we had 80% females who are now certified as mentors versus 20% males throughout the system. These individuals will now serve as mentors when we launch the full phase of the program system-wide. Now, phase 2, we're actually running a pilot right now, which is focusing on aspiring women leaders in finance. And we have 6 mentors and 4 mentees who began a mentoring relationship. Of those 6 mentors, 4 are women. And they're providing mentorship capabilities, they're providing mentorship opportunities to individual women throughout New York City Health and Hospitals who aspire to be in leadership positions within the Department of Finance. And I will pause there for any questions.
Any questions for any? Frida, I see your hand.
Yes, thank you. This is terrific report. I just have a question on the mentoring. So the phase 1, is this all mentoring for women, or is it only the finance pilot program that's focused on women?
So great question. The mentoring itself is focused on developing leaders at all levels within healthcare. It doesn't matter if it's women, if it's male. We're looking at just expanding that mentorship opportunity to all. Phase 2, which is the pilot program, that pilot program is really focused on developing women leaders in finance.
Got it. And of the of the population that's being mentored by the 67 mentors in phase 1, do you have, are the mentees already identified? Is the makeup, the breakdown between women and men
not
sort of equal, or?
Not as of yet. We're actually,
not as of yet.
Right, we're starting to recruit. We're in the process of purchasing mentoring software. As the number gets larger, We have to provide systems where individuals can match to whatever competencies or leadership roles they're looking to aspire to. So the first one was really just establishing capacity or capacity building of mentors without the system, so that we have someone for the mentor, from the mentees to really connect with. So that part has not been connected yet. That's actually this year that we're starting to look at a larger expanded mentoring program, at which point
Okay,
we'll have a
interesting.
breakdown.
Oh, that'll be interesting to see. It's interesting to me that 80% of the mentors are female. It's
It was
great.
predictable.
Yes, well, we want the men to be, men are great mentors also, so we want to encourage the men to mentor, regardless of whether you're mentoring a man or a woman. It's
I have a quick question, Phineas.
Yeah, Jose, do you mind? Dr. Morse have her hands raised before. Is that okay, Jose? Okay, Dr. Morse?
I'll be brief. I don't want to take up too much of the question time, but please feel free to defer this if it's better on a future slide. But I was just very excited to see how many H&H hospitals were included on the Lown Index on racial inclusivity, and just want to congratulate the team on that, which I think is a huge achievement. The two kind of little questions I have on it was, I was curious to know if you have any thoughts about why you think you all have been so successful in the racial inclusivity and ranking so highly on the Lown Index. And then the second was, is it something that's being kind of celebrated? I'm looking at the socialization of diversity and inclusion for all levels of staff, or I was just curious if you all are kind of celebrating that achievement in any particular way.
So right now that's an ongoing project. So this is something that we feel very strongly about. Diversity and inclusion is not just at the leadership level. We want to spread that out to the entire system. One of the things that we're finding as we go out to the system, as we're speaking to the leaders, is that sometimes the knowledge base is held in one area. So let's say, for example, leadership is very well acquainted with the initiatives the Diversity and Inclusion Office has. But the further you go down into the staffing levels, those individuals, there's a need there and there's a hunger to know what's available. So when we go out there and we start providing all this information on, this is what we have for diversity and inclusion, this is what we can provide for you, there seems to be a self-generated method of excitement throughout the system. So we're building on that momentum.
Thank you. Dr. Morse, any other question? Thank you, Dr. Morse. Jose?
Yeah, just a comment on the mentoring program that I don't know how, are we thinking about when somebody's mentored about leadership opportunities and so on, do we have a pipeline so that they can then move on to those opportunities?
So great question. So we're working very closely with talent acquisition. We're working very closely with the system leads in order to identify potential roles and have very focused recruitment fairs for high areas of vacancies and individuals that can do this. But one of the other things that we're enabling as part of the mentoring programs is really educating individuals to take charge of their own careers as well. So mentoring is really giving them the competencies in particular different areas, but also letting them know, we also want you to be a shepherd of your own career, and going in there, getting them acquainted with the systems that we have available in addition. So it's a 50-50. One is empowering them to go after the roles that we have available. And secondly is recruitment fairs targeted at individuals' high areas of vacancies.
Thank you.
Jose, any other questions?
Just and a quick comment on what Dr. Morse mentioned on the loan index and how well we had ranked. I had just a comment that I have had students actually mention to me that they want to work at H&H precisely because they see racial inclusivity being an important component of the system. So just wanted to mention it. Thank you.
Thank you for sharing those anecdotal anecdotes are really valuable. And again, going back to Dr. Morse, how do we communicate our achievement and our work, our values to everyone? So thank you. I just have a couple of questions and kind of follows up on Frida's. If we see the training completions, the mentoring, is heavily populated by women, which again, we should all celebrate. But at the same time, will be good to list what is our percentage or our demographics of men and women, or again, any other categories that we normally capture, that to see, if we have an overwhelming representation from one group or another. Like, for example, do you have the information on what is the percentage of employees, staff that may fall into any particular gender category?
For the mentorship program, we do not at this time,
No,
but we can pull.
no, in general, I'm talking, are we like 50-50, 70-80? Because if we have 80% are women and our population is 80% women, that's okay. That's kind of, we are more or less kind of well represented. But if our population is only, let's say, 40% women, again, I don't know the statistic. I should know it, but I don't know it. But 80% of our mentors and the one that take the training are women. That means an overrepresentation in these groups.
I don't have that readily available, but we can definitely go back and check and review.
I think that would be good to share and maybe pass it along after the meeting so that we have a better understanding, because definitely the numbers are really high in one category versus the other. The other question that I have is, and I think this is great work, great work, and I'm really pleased with seeing how our staff are taking this training and volunteering time, even if we know, from what had happened during COVID, all our staff has been taxed to the max, and they still have time or identify time or make time to support the development and growth of their colleagues. So that's really definitely has to be lauded. But I will be curious to know if there is any particular department that is overrepresented, or the kind of the numbers per department, like for these training completions, are they even across all the departments in the system, in the mentorship, or there is one? Like, again, I don't know the data, but are there more from the nursing, from the pharmacy, from the physician? Is there any data that you have about that? Which department is
Yes.
represented in these groups?
Yes, we have data that we can pull on that. I don't have that readily available for this particular report out, but we can pull that information.
Yeah, if you can share that, because if we have particular take in one department versus another, maybe those departments can be good ambassadors, kind of sharing with all the other departments, why they think this is important, why they believe that it's important to give their time to help other staff. So that may be helpful, and I think we will be curious to know. Thank you. Any other questions? No? May we continue?
Okay. So as was mentioned, we also have 18 designated sites, as the Human Rights Campaign Foundation has designated us for LGBTQ healthcare equality leaders, which is a top honor. And the special designation, which is part of the Healthcare Equality Index, means that our facilities are ranked as leaders in providing expert, culturally competent care to our LGBTQ communities based on these 4 criteria. One is non-discrimination and staff training, patient services and support, employee benefits and policies, and patient and community engagement. In addition to that, happy to report we now have 7 Pride Health Centers of Excellence located in Manhattan, Brooklyn, and the Bronx. The locations for these centers include Bellevue, Jacoby, Gouverneur, Judson, Lincoln, Metropolitan, and Woodhull hospitals. We're also planning on opening the next Pride Health Center in Queens. So we're working with Elmhurst Hospital on that. And then also we adopted Juneteenth as a holiday, which will be celebrated by New York City Health and Hospitals on June 20th. moving forward, just in terms of next steps and the work that we are focusing on in diversity and inclusion, we are continuing to deliver focused D&I training workshops. Right now, we are working on delivering a combating anti-Semitism event, which will be held on May 25th. We are also working closely with Woodhull Hospital and their Sentinel Event Root Cause Analysis Case Review Committee, Correctional Health, and Hospital Police Academies to develop very focused trainings to their workforce in D&I focusing on unconscious bias. So these are in the beginning stages. What we're doing is we're going out, we're meeting with the leadership in these respective areas. We're finding out what are their needs. And then based on that, we go back, we speak to our partner vendors, and they develop customized solutions, customized training to their workforce. In addition to that, we're going to continue with our D&I socialization strategy. With now moving on, we've met with the leadership, we continue to meet with the leaders, the CEOs, but now we're going to be participating in facility-specific town halls. So every facility will have a town hall for their workforce. These town halls will be recorded, will be made available for those that can't participate. And the town halls will really be an opportunity for all staff to know, one, what is going on with the D&I office, what services we can provide, and also how they can participate and become part of some of our initiatives. We are also going to be providing table setups to create an on-site presence, again, distributing D&I information and the services available. And we are in the process of creating one-page summary sheets for each facility that can be distributed to staff so that all staff knows what their facility focus is in terms of D&I. So for example, at Metropolitan Hospital, we offer gender reaffirming services. So we want all staff to know that. And so we're developing that one pager so that each staff is very well acquainted with their particular facility and can also use that education to educate our patients and also increase the number of patients that choose us as a provider of choice. In addition to that, we're updating the website to reflect strategic initiatives, what we're working on in the D&I office, as well as continue to make it more user-friendly for those that visit the site. And then we're focusing on our diverse pipeline initiative, which is we're working with CUNY, and we're looking also at historically Black colleges and universities, any schools that are designated as minority serving institution, Hispanic serving institutions, and we're going to be inviting them to participate with us in career workshops, in internship opportunities, to really provide an opportunity for these students to get exposure to New York City Health and Hospitals and potentially make up our future workforce.
Before you, continue this, okay.
Okay. In addition to that, for our existing workforce, so for those employees that may not have access or the ability to go to continue their degree program, we're partnering with LaGuardia Community College to participate in the new program that they have, which actually awards them college credits for life and work experience. This will provide employees with up to 16 free credits towards a degree, as well as career counseling and coaching. And we're going to be providing this through marketing to inform our workforce of the program. So this is a unique opportunity for those individuals that may have been considering going back to school and have not done so to receive very structured, guided support, as well as save some money because, again, they'll be receiving 16 free credits. And then lastly, our mentoring programs. As we continue to expand on the mentoring program, we're currently working with our nursing department, and our 2022 mentor cohort includes 49 nurses that are currently being trained as mentors, and these nurses will be specifically focused on mentoring their fellow nurses. And then that will be followed by phase 3 of the program, which is system-wide expansion of the program, whereby we will make mentoring services available to staff across the system. And that completes my report. If there are any other questions.
Thank you. Let me ask the members if they have any questions. Okay, any questions?
Questions, thank you.
Thank you. Dr. Katz? Sally?
I just, I guess we've had this discussion a little bit before, that's the importance of exposing young people in high school to the opportunities that exist as well. A long, long time ago, there were specialized high schools for things like nursing, um, and which I don't believe exist anymore. I don't know how much we do at the high school level, but it seems like that's a place we should be focusing on.
So thank you for that. In my role as the co-counsel for CTE and the New York City Board of Ed, that's exactly what we're focusing on. We're building upon that population. Just last year, we held, during the height of COVID, we held a virtual internship opportunities, which we called WOW. It was focused on New York City Health and Hospitals and what we were looking for in our employees. So we spoke to them about the civil service process. We spoke to them about different roles. It was held in a completely virtual environment, but it was kind of a pipeline to get those high school students interested and ready and wanting to come to New York City Health and Hospitals.
That's terrific.
Thank you, Sally. Frida?
No questions, thank you.
Thank you. Dr. Morse?
I'm great, thanks.
Dr. Martin?
Yeah, fine, thank you.
Thank you. I just have a couple of questions. If we go back to the previous slide, in terms of the pipeline, do we have any particular goal of the number of students that we would like to reach, and how many of them we would like to offer them opportunities to work in our facilities, either during their schooling, med school, or after, or are these just exposing them to the health and allied sciences fields?
So that's a great question. It's a combination of the two. So again, when we get students and we recruit them, that's all guided by the vacancies that we have in the system, particularly the entry-level vacancies. But I can provide you with an example of something else that we did during the pandemic. We worked very closely with Helen Arteaga at Elmhurst, and she made her entry-level position. She made several for the program that I was speaking about earlier, the WOW program. Not only did we provide internship opportunities, virtual internship opportunities, but individuals who successfully completed that program were made available to vacancies that they had as patient transports. And so she had a select number of vacancies, which she made available to this particular high school. And then from the individuals that participated in the internship program, then they were invited to interview for the roles and subsequently hired. So it varies by the facility, it varies by the role, and it also varies by the needs that we have at New York City Health and Hospital, particularly when you focus on entry-level roles.
Okay, thank you. This is very, very helpful. Thank you. No other questions? Keith, are you going to?
Yep, thanks.
Present now?
Sorry, I'm just
Okay,
waiting
thank
for
you.
you to pitch it to me. Good morning. Thank you for the opportunity to present today. My first slide here is a slide that we had finished up with in prior meetings discussing the program development. So in March 2021, we adopted and issued our vendor diversity policy. And since then, we've been working hard to make sure we have the best programming in place. So we've been working hard on the procurement process piece, which is kind of the backbone of the vendor diversity process to ensure that we touch on all key aspects of the procurement pipeline. So we refer to that as procure to pay. We're just going to stay on this slide. I shortened up the slide deck, so I'll speak to this slide. But really, it's a procure to pay process. So right from the outset, there are key opportunities for MWBEs to be considered, and that's at the procurement development phase, then through the other key touch points to the proposal phase, the award phase of the contract, the contracting itself, and the onboarding of the vendors and their subcontractors, compliance with the goals, and then payment. Payment's a key issue for our diverse suppliers, often small businesses. Actually, if we could just stay on that other slide, please. It's all just kind of wrapped up in that little red bubble there. So on the procurement aspect, 100-5 is our procurement OP, 100-10 is our supplier diversity OP. The procurement OP requires consideration of vendor diversity at all aspects, and the vendor diversity team sits with the supply chain team together on the same floor. That is, the kind of unified approach that we have to all procurement across the system. And we sit together in weekly meetings analyzing the procurement pipeline and considering the vendor diversity aspect a key element of each review of the opportunities within that pipeline. And then what do we do for each of those? We look at the key tools for MWBE, discretionary awards for contracts less than $1 million, closed pool solicitations where there's significant MWBE availability and capacity, goal setting, and as well as unbundling of larger contracts as appropriate. We research and directly invite MWBEs to participate in each of our procurements, make sure that they get a warm handoff of that solicitation and are able to respond effectively that way. All of the RFPs themselves are reviewed by my team to make sure that the language is appropriate to maximize participation both from prime MWBEs as well as subcontracted MWBEs. And we also attend the pre-proposal conferences. So that's an important step along the way to ensure that prime vendors that are not MWBE understand the significance and importance of the program, that they understand that they will usually be measured objectively and scored on the MWBE utilization plan that they submit, as well as offering matchmaking. So that's an opportunity where primes looking for MWBE subs to participate in their contract will often find those subs. The next phase is the proposal phase, where my team reviews the utilization plans that are submitted by the prime vendors, as well as the certification status of any prime MWBEs that are proposing on the solicitation. And then we objectively score all those proposals against the scoring criteria for the MWBE component. The next phase is the awards phase. So that's where we make sure that vendors have maximized their MWBE opportunity if they're not an MWBE. And one of the things that we've developed is we review all the utilization plans that the vendors submit. And sometimes we get surprised in finding a key area of subcontracted scope of work. So if we thought it was training, and then we see another vendor submit a proposal and we see that there's hosting, for instance, if it's an IT contract. And then we go back to the awarded vendor if they didn't have that scope of work in their proposed utilization plan and try to negotiate that in as well. The other thing we address at the award phase, of course, is waiver requests and as well the disparity within the disparity. So if the utilization plan is leaning heavily towards non-minority women-owned businesses, we will ask them to maximize their utilization of Black and brown-owned businesses. The next key piece is contracting and onboarding. So we ensure that the contract itself contains our key terms, which provides remedies for the system in case of vendors' failure to perform good faith efforts against the goals that we have assigned on the contract. We have a conference with an agenda sent out to all the primes and subs on each contract and have a discussion on that phone call about goal setting, the expectations on the contract to make sure that they understand how and where to provide the compliance data to us on a monthly basis. The next stage is compliance. So making sure that that data is coming into us monthly. We've developed a weighted heat map scoring for all of the prime vendors with goals in our system to make sure that we are addressing any potential failures to perform against the goals. And then we reach out to those primes, of course, to start with. If the primes are non-responsive or providing an insufficient answer, we set up a conference with the senior business owner for that contract, as well as myself, and escalate as appropriate. Finally, payment. So I mentioned that payment is an important component. We make sure that both H&H is paying our direct MWBEs as well as our primes to our subs, working with our AP team, our sourcing team, and our PeopleSoft team to make sure that everything's in place to ensure there's timely payment. You know, our goal is really 30 days for all of our MWBEs. We're not there yet, but we are working on it. Okay, so I can stop there for questions or move to the next slide.
Any questions?
I have a couple.
No.
I have a couple
Yes,
of
Sally?
questions. Yes. That was very useful delineation of the process. I have 3 questions. One, you mentioned 2 categories. What I think I heard was potential sole source if it's less than $1 million, and a closed solicitation when you have enough MWBs. Is that correct?
Not sole source, but discretionary, but yes.
Discretionary.
Correct.
But you could select someone
Correct.
if the contract is less than $1 million. Okay. And then I think you spoke to it, but just more directly, I think my experience in working with MWBEs, there were 2 concerns. One, we want to make sure that we evaluate their work as well in a timely manner so they can get the feedback they need, both for the contract they're working on as well as potential future contracts. So do we have an evaluation phase for the MWBEs?
So across supply chain and OFD and IT, we're actually working on launching a new vendor management program. Christine Flaherty's shop has software that they're, I think, currently soliciting for that to provide that feedback on an ongoing basis in, you know, a routine and orderly way that includes them. At the moment, we do not have a formal process for that though, and supply chain itself is also onboarding software and team members to work for vendor management. And we have a process to flag those items that require close follow-ups, and our key strategic contracts all have quarterly business reviews, but nothing specifically for smaller vendors to that end at the moment.
Okay. And my second question related to cash flow. You know, you can kill a business by giving it too much business. I'm wondering how you monitor the capacity of MWBEs.
Sure. So when we do that availability and capacity analysis, that worksheet has the vendors' you know, annual revenue on there, as well as their largest contract awarded. So when we look to those subcontracted scopes of work, we try to make sure, you know, they're not like 2x or 3x or 10x, right? So it's something reasonable. If they are, you know, more than their current annual revenue or their largest contract, we will have a discussion with them about capacity.
Okay, thank you very much.
Absolutely.
Thank you, Fanny.
Thank you, Sally.
Thank you, Sally. Any other questions before we proceed? Jose? Frida? Dr. Morse? Dr. Marton? No? Okay. Thank you. Okay, Keith. Yeah.
Thank you. So the next slide. So we've seen this slide before. This is just a reminder of our numbers over the past several years and some of the efforts that we've implemented to help drive that utilization, with last year $419 million in diversity spend and a 28% utilization. Next slide, please, just in the interest of time. I'll move quickly on these 2. So these are the detailed breakdown of those numbers. So you'll hear me repeat that often. Our eligible spend, that top box, is about 50 to 60% of our total procurement dollars. Things that don't fall into there are affiliation agreements, complex clinical goods, as well as pharmaceutical supplies being the bulk of what comes out of the total eligible spend. Total contracted spend right there is our direct spend with our diverse suppliers. Total subcontracting spend is through our utilization plans and goal setting. And I think the rest is self-explanatory there. Moving to the next slide, please. So major accomplishments. This year, we've already exceeded last year's total MWBE spend just through Q3. That is both categories, direct contracted spend and subcontracted spend. We have converted 29 non-New York City certified MWBEs to get certified by the city. That's a big accomplishment for us because that's really a lot of the day-to-day hard work that we do, trying to find additional vendors to provide services and support our overall program and our partners. We are doing business with a total of 33 new diverse vendors. We're on target to achieve 30% utilization at the T2 vendor testing pool for COVID testing. We've worked with OFD and CBRE to place goals on a large strategic contract of theirs with an overall utilization plan of 37%, representing $37 million in MWBE award. And it's something like, 40 vendors under that contract. So that was a lot of hard work by the team. $205 million in direct spend with the New York City WBE for COVID-19 test kits, primarily distributed to the schools through T2. We've partnered with EITS to include NWBE quantitative scoring on all of our goods purchases over there. So this was a big win for us. It sounds simple just to add 10% MWBE on a bid score, but it's a lot of work and partnership and understanding with a lot of stakeholders as well and in their budgets as well. But that has really changed the overall composition of the awardees on that pool of contracts. From really non-MWBE mostly to now a large majority being MWBEs. Closed pool solicitations, we had a few big ones this year. Contract for clinical cart maintenance through Kim Mendez and Jeff Lutz. $10 million for Get Food, closed pool solicitation through T2. $4 million award for T2 Creative Marketing Services. Next slide, please. So as the program development develops and we have some of the hard granular work behind us, we are spending more of our efforts on communication and outreach. We have joined our GPO's premier Supplier Diversity Council membership. They meet quarterly as well as in Washington, D.C. and help make strategic decisions for the GPO about contracts and vendor relationships. NMSDC and WeBank are two very large national certifying agencies for diverse businesses. NMSDC for National Minority Supplier Development Council for minorities, and WeBank, Women's Business Enterprise National Council. Those two we will be working with closely, sitting on their council, attending meetings, mentorship program and opportunities there as well. We meet bi-weekly with the Mayor's Office of MWBE. We attend the quarterly New York City MWBE Directors Meetings. We are attending the City and State Diversity Summit that's put on by the state system, as well as attending in DC Premier Breakthroughs Conference. Some upcoming strategic opportunities for us. So we have been goal setting on all of our procurements across the system. Additional opportunities sit with our construction bidding. So we do some hard money bids through Christine's shop for standard construction work. Typically, we have been placing 30% goals on that. We know from the data that there's additional opportunity there above 30%, and we have begun that work. As well as goal setting and compliance on construction work orders. So we have requirements contracts where we issue work orders against. That's been a bit of a challenge to stay on top of, since there's so many work orders being issued and it's a lot of transactional work. But we are working with Christine and their new software opportunities to make sure we are able to stay on top of that work. Strategic sourcing opportunities for I'm not going to go through each of these, make sure Jeremy has some time here today, but print and promotion, maintenance, repair, and operations, and our Dell desktops were standardized to. Our temp staff efforts, as you know, we have a very large temp staffing program at H&H that's managed by our vendor Right Sourcing. We have, through the software, provided all new opportunities for each new staffing need across the system to our MWBEs first for 72 hours. That has not delayed time to fill on any of those positions and has increased our utilization through that program by 5 percentage points. And then our next steps here, our immediate next steps are to launch our new website, further develop our communication, and next slide, please. Continue to develop our communication outreach program, as well as optimize our capacity development efforts, where we work with our smaller vendors and our larger primes to help drive business growth to our smaller vendors, both in terms of dollars and expertise performance. Thank you.
Thank you, Keith. Let me just ask the committee members if they have any question. Jose?
No questions, thank you.
Dr. Katz?
I don't know if it's hard to put back the slide showing the dollar amounts. Can you do that? Go back. A little more back. Yes, so I was just, as I was looking at this, remembering the old Jerry Maguire movie and Show Me the Money. And, you know, I mean, this is just such an amazing, you know, achievement. And this is real money. This is not like awards that may or may not happen, right? This is like money that is really supporting our goals. And I think this is huge. Many people talk about, the goals of increasing diversity and inclusion, but don't always, have a strong data to show that they really did it. And I think this is really, really amazing and something that the purchasing team should, and all of the other parts of H&H that contribute to this, should be very proud of. So thank you.
Thank you, Dr. Katz. And I just would like to say that I echo your sentiment. And definitely that's a great model to live by. Show me the money, talk is cheap. So in this case, these are spent money that has gone into the hands of NWBE. And we see it's almost $500 million. You have to put it in context. Doesn't sound as well when you say over 400 million, when you say almost $500 million. I don't know why, but the B does have power. And also what is very impressive is the number of diverse vendors. This is not concentrated in the same vendors, but you also went out and outreach and spread this money into the communities. And we all know that money spent in these vendors really have a great impact in the communities where these vendors are doing business. So I just want to echo Dr. Katz, your comment. This is really an impressive accomplishment. Sally?
I'm just in awe of the work that you do and you have done. To do this in 1 year during some of COVID, to just not do the low-hanging fruit, but to really look for areas and on a much more granular level, continue to expand the work you're doing. The software is going to be a tremendous benefit. I think it'll be helpful, particularly for the MWBEs, to make sure they have the guidance and the support that they need, because that's just critical. We don't want to ever be found that we're people are treading water. We want to make sure they're adequately supported. But it's astounding. It's just astounding, Keith. So I congratulate you and everyone, who's been involved in this effort.
Thank you very much, Sally.
Thank you, Sally. Frida?
Well, I think everybody has said what I wanted to say. It really is remarkable, the progress and you describing all of the steps that you guys have taken and the efforts. And it's a huge investment. We recognize that, and time and focus and creativity on how to do that. And that you still have, goals, and you're pushing yourself forward for more. And I think that's terrific. The one thing I would like to just mention also, because you did spend a lot of time describing the RFP process to us, which I think was really helpful and very informative. We sometimes do, and you alluded to, that we have some spend that isn't possible to be captured under these kinds of contracts. And so in those cases, and we've talked about this before in other contexts, I think it's helpful to think about the firms that maybe can't subcontract out and are not minority or women-owned firms to to delve more into their diversity practices and what they're doing and how are they trying to develop leadership in their firms and organizations, and to try to wrap that into your procurement process as well. In those instances, I think would be a great thing to keep pushing our message and goals forward.
Yeah, absolutely.
So
We've begun to take a look at that together with Danielle and Andy, and looking at best practices across the state and the country to that end, and are definitely looking to add that into our program in some aspect.
Great. Thank you. And I'm sure you'll do great because of all the terrific work you guys have done already. So the bar's set high.
Thank you very much.
Thank you.
Thank you, Frida. And actually following up on your comments, this is something that is very important because it's true, some firms, because of their current model, may not have the ability, but that doesn't mean that they should not try, and they should try to put forward what is their plans to diversify their supply chain or their value-added environment and ecosystem. And we have seen how both industry and governments have been asking for the ESG, environmental, social, and governance. And I think those are very important criteria on how they will ensure that they have the mechanism to have a more diverse ecosystem of companies working with them. So I think this is something that is very important for us to continue the discussion and looking forward how to implement that as part of the procurement. Dr. Morse, any question?
Thanks so much. No questions.
Thank you. Dr. Marton.
I don't have any questions, but I really wanted to reverberate the comment that I heard Frida make about really looking for those that are not MWBE organizations and just trying to make sure that they as well are really diversifying and looking at their makeup. And the titles that they have are so important because you can hire diverse people, but what roles are they playing in your organization? And I think that speaks volumes to the goals of H&H, and I think it's exceptional that you've reached out to that point, that you are really forward thinking on what diversity really would mean in this case. So congratulations, and thank you for doing the work.
Thank you.
Thank you, Dr. Marton. And Keith, I just want to echo what you have heard already. Great job. Congratulations to you and your team and the whole health and hospital, because I know it takes a village. And I think this village has been working very diligently while they are being pushed in so many directions, pulled in so many different crises, but they still have that true north to support the diversity of our vendors, represents the diversity of our patients and really our community. So thank you, and please send our most fervent thanks from the board to your team and to everybody that has made this possible.
Thank you very much.
Thank you. So now we are going to Jeremy. Jeremy?
All right. Good afternoon, Penny and the board and esteemed colleagues. I just want to say it's always a privilege to be able to sit at this table. And although I do have a mask on, I am smiling ear to ear because I have immense pride working for NYC Health and Hospitals, and the ability for our executive leadership and board to walk the talk in terms of diversity, equity, inclusion, and humility. I really value working for this organization. As I go into talking a little bit more about our employee feedback survey findings, you'll also see that that's echoed throughout our workforce. So just to talk a little bit about the demographics, if you will, about our employee feedback survey. This survey went out to all of our employees, full-time, part-time, affiliates, some contract workers as well. And it was split up into two separate populations, the general employees, and then our advanced practice providers, which I'll define in just a few minutes. Something just to mention in terms of our employee feedback survey, it's a moving target, not only in how many of our staff members we can capture at any given time, but also in the amount of time it takes to get the results back and to really see how action planning has really impacted some of the data that you'll be able to see as we further break it down. The survey itself was actually a beautiful collaboration of a multitude of different offices, including Human Resources, our Patient Safety Office, Office of Patient-Centered Care, Communications and Marketing, as well as the Office of Quality and Safety. It was both a qualitative and quantitative survey. The quantitative data was broken up into a 5-point Likert scale, and we also had qualitative questions that were open-ended for commenting, specifically on direct questions, as well as for us to attain feedback from our employees. It cascaded over a beautiful umbrella that looked at engagement, so that's employee satisfaction, safety culture, nursing excellence. We also had specific diversity and LGBTQIA plus modules, which is what we'll actually be diving deeper into in just a few moments. We looked at crisis management as well as well-being and resilience in this survey as well. The survey went out to over 48,000 employees. It was an electronic survey process, so an email went out from Dr. Katz, followed up by human resource reminders. We did a QR and papering campaign. We had kiosks across all sites and service lines. So this was for all that are able to see themselves as part of our enterprise. In terms of our employee response rate, we had 37%, so over 13,000 employees did complete the survey. For our advanced practice provider response rate, we had 17%, which is over 2,200 employees. What we are starting to see nationally as a trend, because we did use Press Ganey as our vendor to help support this confidential and anonymous employee feedback survey, is that across the nation right now, you're seeing healthcare systems have between a 10 and 30% response rate. So it shows that our system, despite all the adversity through the multiple waves of COVID, we really did have a nice turnout in terms of the employees. It was disseminated between September 13th and November 3rd. And just to break down our survey population a little bit further, Black African American workforce members made up 33% of the survey, followed by Hispanic and Latinx with 20%. We also had 18% of our Asian workforce members completed and 15% of white or Caucasians. We also did capture American Indian, Alaskan Native, Native Hawaiian, Pacific Islander, as well as 2 or more races, other or prefer not to answer. In terms of gender identity, females made up 72% of those that took the survey, followed by 24% male, as well as other made up 1%. In terms of transgender, female to male, transgender, male to female, genderqueer or non-binary, or gender non-conforming, they all made up less than 1% of survey respondents. In terms of sexual orientation, non-LGBTQIA+ workforce members made up 86% of the respondents, followed by 4% that identify as LGBTQIA+. And then we also did have others that stated other or preferred not to answer, making up less than 1%. And in terms of generation, our Gen Xers, born between 1965 and 1981, made up 44%. Millennials, 1982 to 2000, made up 25%. And our baby boomer population, 1946 through 1964, made up 24%. And then just taking a look at our major disciplines, we obviously captured all divisions, all departments and disciplines across the organization, but our registered nurses made up 23% of those that took the survey. Management, so that's anyone coordinating manager above, up into vice president, took 22% of the survey respondents were them, and then clerical workers, 15%. So today, as we go to the next slide, we're just going to be discussing the diversity and LGBTQIA+ modules. Again, they were standardized question sets, as well as custom questions that we were able to make in partnership with the Office of Diversity and Inclusion. So just for some background information on the survey, NYC Health and Hospitals question set, again, it was 10 questions, 3 of which were customized for our own system so that we could have national comparisons, as well as our own internal data for action planning and improvement purposes. Again, the questions and the entire survey was administered by Press Ganey, and really we focused in this module on perceptions of diversity specific to the groups that I have mentioned. The metric summary is something that we absolutely have to celebrate as an organization. This was the highest ranking and rated module in all of our employee feedback surveys. So diversity was the highest scoring category compared to all other survey domains. Overall favorability, 74% with a 3.91 score for employees and 84% favorable, 4.9 score for providers. All measured items within the category were greater than 60% favorable with a score of at least 3.56. And just something to share in terms of what does favorable and non-favorable mean. Unfavorable represents the sum of disagree or strongly disagree responses as a portion of the total subset. Neutral represents the neutral responses, and then favorable is those are employees that were saying that they either agree or strongly agree with our diversity question sets. So both employees and providers showed highest favorability, over 80%, within statements regarding LGBTQ staff receiving same benefits as everyone else, the organization not tolerating bias against LGBTQ, and the organization protecting LGBTQ staff from discriminatory practices. And as a workforce member that has worked for NYC Health and Hospitals for almost 12 years, I remember when we became an allied organization. So to really see this culture shift in practice and in understanding and connection with our workforce is really beautiful to see. In terms of peer group comparisons, so we were able to compare our safety net system with the American Essentials Hospital safety net database. And what we are seeing is that our providers, our advanced practice practitioners, again, that's going to be your MDs, your DOs, your PAs, as well as NPs and non-MD advanced degrees, they ranked higher than the nation's safety net system. So that's an aggregate score, so we're doing quite well there with our providers. And in terms of our employees, very close to the national safety net aggregate as well, only just a few points off. The key insight here, which is really beautiful to see, not only through the national trending through Press Ganey, but to look at their correlating data, is that any organization that has favorable scores, so again, agree or strongly agree, actually shows that they are able to retain employees longer if someone were to receive a different job offer or if they were going to leave the organization. So they would generally stay for longer than 3 years. So if your organization has unfavorable scores, those employees are 4 to 5 times more likely to leave. And so this is, again, something for us to be celebrating, something, as we talked about before, to communicate more widely for recruitment. It's incredible to see. And another data point that I think is really important to speak on is that if the staff feels seen, heard, respected, celebrated, and recognized, if the staff believe that they not only have colleagues that look and come from backgrounds that are similar to theirs, let alone to actually be able to practice and support care of populations that are of their own, they're also more likely to feel as though that they want to stay in the organization because it has a deeper connection to the work that they do. It shows them that they're making a difference. And so that's something that I just want to name as well. So if we go to the next slide, just quickly breaking down, I'm not going to spend too much time on this. So the blue column is really all of our favorable scores. So again, you'll see that we ranked extremely high across all of our diversity and LGBTQIA+ domains. At the top of it, you'll see is the roll-up aggregate for diversity. On the left side is your employees. The right side of the screen is your providers. Just doing some incredible work here. I'm not going to go through each point because I realize we're running short on time. But even our custom question sets in terms of trust, in terms of diverse backgrounds, working well together, as well as us valuing employees from different backgrounds, all of those were our custom questions, all also ranking extremely high for our organization. So just some beautiful work that's happening on behalf of the committee, on behalf of the board, in actual practice, day-to-day in operations across all care settings and service lines. And if you have any questions.
Thank you, Jeremy. Let me go through the members to see the list of the members to see if they have any questions. Jose.
This looks great, Jeremy. So on the one that you have there that talks about trust, and do you have any thoughts on that one that scored low, trust and?
So even though it looks low, that's still 63% of all 13,200 plus providers saying that they actually strongly agree that there is trust in their work unit or department. What we've learned through digging deeper into this data is that trust is based on a few things: competencies, capabilities, communication, and transparency. And so this is an opportunity for us to really look at work teams and how they work together, not just looking at the managers, the leadership in that specific area, but the team members themselves. Are they empowered to utilize their voice? Are they empowered to practice the top of their skill sets? Do they feel as though that they can practice autonomy within reason to the scope of their work? So it is definitely multifactorial, but even though it's only quote unquote 63%, what I want to bring your eye over to is the neutral category. So a lot of what we've talked about today is, again, is the workforce really understanding what that really means? How do we define trust? What does trust look like? What are we doing as an organization to enhance trust and build it and to reinforce it across our system? So that neutral category, that's 22%. We have a great opportunity there to work with the workforce to show them how we're trying to make strides in terms of trust. And the last thing I'll say about trust is it's all about psychological safety. And so does our staff feel safe enough to see something, to say something, but also to be heard and to not have that be a punitive action or to work against them in the court of public opinion. So we're doing some tremendous work across NYC Health and Hospitals to enhance psychological safety through a variety of different initiatives and programs, specifically helping Healers Heal, our workforce wellness, as well as all of our employee engagement and incredible things that's happening also through the Learning Academy. In terms of how to be more empathetic leaders, how to actually focus on some of those management skills that would actually enhance trust building across the team.
Thank you so much. Very impressive work. Thanks.
Thank you, Jose. Dr. Katz.
I appreciate both the responses and the fact that we're the kind of organization that does this kind of look. So I think because you can't know unless you actually feel safe enough yourself to check and see. So I thank you, Jeremy, for the work, and I'm very pleased with the results.
Thank you, Dr. Katz. Sally?
I echo the tremendous work that was done. I had two comments. One, nurses and management were fairly high percentages of participants. I think clerical was about 17%. Is that what we typically see in surveys? Do we see
Yeah, I have to say what's really unique about this survey is it is very much representative of the breakout of our actual workforce. So nursing obviously being one of the largest disciplines across the organization, it makes sense that there'd be about 23% of RNs that took it. And then we break that down even further to LPNs, nursing assistants, clinical professional assistants as well. So it's broken down by layer of the organization. We can split the survey in
I can imagine, yeah.
And so I kind of showed you just like the major categories that took it, but I have a full breakdown if ever you're interested in looking at it. It's a lot of numbers.
Any survey that gets a 37% response rate is incredible. It's incredible. You just don't get those kind of response rates on surveys.
No, you don't, especially during the climate that we've all been through over these 4 waves of COVID. So I'm very proud of our system for showing up and also for allowing a space for our staff to have their voices heard during these challenging times.
Congratulations. Good job.
Thank you, Sally. Frida?
I agree. In the interest of time, there's so much great data here in the work, and what you just said, and Dr. Katz and Sally, it's taking the time to do this, asking very deep questions, and getting the response rate. It says a lot just in and of itself. So thank you.
Thank you, Frida. Dr. Morse. Dr. Marton?
Thank you.
No question, Dr. Marton?
No question, thank you.
Thank you. Jeremy, again, I just want to echo the comments that have been made. Impressive work, really great results. My only question is that, is it possible to break out this survey to see, here you have all the respondents, and only looking at the respondents that consider themselves or self-select to be LGBTQIA+, to see if there is a difference between the feeling of the people that, are represented with the majority. Do you have that breakdown?
You can absolutely break it down by demographics. So any of the demographics that I shared at a very high level, you can split out all the specific scoring aggregate roll-ups to those demographics as well. So we can do that across any of the categories.
But I know that the numbers may be small. I think you mentioned the numbers, but do you recall any big difference between the overall and our staff that are LGBTQIA+, or they are consistent? That means the responses is very similar. Like, for example, when you ask the question, there is a climate of trust within my work unit, which is kind of the lowest for the overall. Do we see similar, or do we see greater feeling of mistrust? I just don't know.
First of of all, I respect the question, and the answer to that is there's no major discrepancies across those two domain categories. But again, it really varies by service line, site, facility. So, but at a system level, no major variation.
Okay. If you don't mind, it would be, at least I would be curious to see the breakdown, like for our staff that, LGBTQIA plus and the overall, that would be something helpful.
Absolutely.
Thank you. Next, I think is Dr. Sines and Dr. Davis.
Yes, good afternoon. Today we're going to have our leads for the monitoring and evaluation group present. We have Dr. Kamal Bajaj and Stephanie Majak here who've done a great job with our data. Dr. Bajaj?
Thank you.
Hi, I'm Stephanie Majak from Data and Analytics. Your mic. Hi, I'm Stephanie Majak from Data and Analytics. I'm Director of Data Literacy. Thank you for having me. Our first slide is so this is just the structure of the Equity and Access Council. Great. And here, so I am co-chair with Dr. Bajaj of Monitoring and Evaluation Committee. And we wanted to develop a charter that explained what our role, something happened there. Sorry, we developed a charter that explained what our role was in supporting the Equity and Access Council. And so our main role in supporting Equity and Access Council is development of MMKs and continued focus improvement for data solutions with continued support of Equity and Access Council. And we are also supported by a very talented group of individuals from across the organization, from clinical in our ACE core to quality, Dr. Lindell Campbell in quality and safety that works with Dr. Bajaj, to people in EPIC EMR, and also diversity inclusion as well, which we believe was implemental in us getting this project being successful.
Thank you, Stephanie. Next slide, please. In order to build the foundations of equitable care so that we can break down structural barriers to our patients' best healthcare, we recognize that effort takes capture of data. We have to analyze that data and then make improvements, whether it's improvements in the data collection process itself or to use that data then to make improvements in other areas. And as Stephanie mentioned, this has been a remarkable effort between our EPIC colleagues, our data and analytics folks, central office quality and safety, as well as the office of ODI. And certainly my name is Komal, I'm the Chief Quality Officer at Jacobi NCB. This has been a tremendous opportunity, and I really appreciate the opportunity to do this work and be here with you today. Next slide.
Okay, so this is more about our approach. So to begin the process, we worked with subject matter experts from across the organization to propose measures, metrics, and KPIs put forth before the governance committee. And our governance committee is a representative body of leaders that work with, that are aligned with our ACE core, and who are also made up of a collective body of leaders from across the organization, and they're responsible for confirming, enforcing policies and procedures. And they will submit these lists of values for ratification. And once that is done, the list of values for ratification is for the purpose of us using, so the hospital has one uniform language that they're using for reports and dashboards for reporting. Once that's done, we're able to, and that's also used for the Equity and Access Council. We capture and clean the data for access and measures for MMKs. So we took the targets that were presented. This was a project that was began by Dr. Hart in early 2001. Now these targets were set by Dr. Hart. They were somewhat arbitrary. The initial target was 75% of the patients within EPIC who wanted complete race and ethnicity data. When looking at the targets, like I said, they were somewhat arbitrary. We had no frame of reference and whether they were achievable or not. And we have been able to get some handle around them and look at some of the data. So by looking at 75% of the patients in EPIC with complete race, ethnicity, and preferred language, we took that to mean that all three of those areas had to be populated for patient data. Within EPIC right now, 42.5% of our patients have that information completely populated. If you drop that down to 2 fields, then 57.5% of our patients have that information calculated. The next target was that less than 10% of our patients within EPIC would be listed with something else or choose not to disclose for their race, ethnicity, and preferred language. So 57.5, as I stated, had language incomplete. Specific race, ethnicity, language, 26% of our patients have that information completely populated. But if you look at that 26, and non-specific language, ethnicity and language, those are patients that choose not to disclose any information at all. We have a total of 16.5 that said something else, choose not to disclose, or unknown. Of this 16.5%, a 9.8% of those patients are listed as Hispanic Latinx. We thought that was actually quite significant to look at. And then 26% are totally completed for language. It seems like a low number, but considering 16.5% are all non-specific, we thought actually it was an interesting data point. Next slide. And this is just a high-level view of our process. So in April, we put forth for the governance committee, the list of values that were put forth were standard naming conventions for our technology systems. And then in November, it was the first time that we put forth an aggregated list of values for the ethnicity. It was 11 aggregated list of values for ethnicity and race enterprise dashboard reports. Next slide. And so what are we doing now? So our progress is that some of these aggregated list of values or the MMKs are now being used in dashboards. And this is some dashboards from population health. So this is where some of our, we're seeing some of our data being used now.
Next slide. Thanks, Stephanie. So we realize that, there's a huge concerted effort to, one, understand the definitions and then also improve data collection. We also need to equip our staff who are doing improvement work to be able to apply an equity lens to their improvement work. So you see from this slide that Quality Academy, which is a 6-month program to train our frontline staff in improvement, we held a robust session on applying an equity lens to improvement work. Next slide. And for those that attend our QAPI meetings, you can see, next slide, you can see that our reporting template includes not just what are you trying to accomplish in baseline state and the process outcome and balancing measures. We also now include a separate box which includes the equity lens. And what we're asking folks to do is when you're looking at your outcomes, and we want to make sure that different groups are experiencing those outcomes equally. And by applying an equity lens, thinking about what might be a structural barrier of care, we can see whether different populations experience the gains that we're seeing in aggregate. Next slide. And so we wanted to share with you at a system level for about this represents 2 quarters worth of application of the equity lens. And these are the lenses that were applied for all completed PI projects that were submitted to the board. And here you can see that, we're not dictating what lenses people use. They're really sort of taking, sort of a think about what might be a structural barrier to the project that they're working on. And you can see the sort of spread here. Next slide. And as Dr. Katz said, if we don't look for it, we won't find it. And of those 49 completed PI projects, 9, so about 20%, there was indeed a disparity that was discovered. And then, of course, the next test of change will be to work specifically to close those gaps. And so I think this is a real testament to our system that not only are we doing great improvement work, we're looking to see if there are intervention generated disparities and working to close that gap. That's just really, really powerful information. Next slide. And so our next steps really are multi-pronged. One is to sort of continue education of the ratified MMKs as identified and work with our business analysts to ensure that those are understood and that they're implementing them. We want to be able to equip all facilities and departments with their data. We want to be able to tell folks, at your site, X percentage are completed, and here are potential areas for improvement. And then continued focus on the intervention data disparities and ensuring that when a disparity is found, that there are additional PDSA cycles that are specifically focused on addressing those gaps. Thank you.
Thank you. Is that the complete presentation, Dr. Davis, Dr. Cisneros?
Yes.
Let me ask the members for any questions. Jose?
No questions, thank you.
Dr. Katz?
No questions, thank you.
Sally?
I don't have any questions, thank you.
Frida?
I don't have any questions, but I just want to say that this is really amazing, and thank you for sharing it with us. And I hope, well, I actually do kind of have a question. Do you think we are at the forefront of this? Are there others that are doing this? Because this is just great, capturing the data, processing the data, and looking at ways to use it. And would love to be able to get that out broadly. I'm sure you guys are thinking about that. But.
Yeah, thank you for that question. So absolutely, I think that large health systems are working on trying to collect their data. In fact, other systems in New York have also sort of established campaigns to partner with their patients. But I think this ability to sort of embed it within our improvement work and really think deeply about intervention-generated disparities, I certainly believe that we are on the leading edge of that work as a system.
That's great. Thank you.
Thank you, Frida. Dr. Marton?
No questions, thank you.
Thank you. Again, I just want to echo very impressive work. And I know when we started this was not a long time ago, putting the committee together, and you have come a long, long way. You have very clear KPIs, a very well detailed and crafted plan. So I just want to congratulate to the whole committee and to all of you for your leadership. I think this is very, very impressive. I just have a quick question. I know that we're running now very, very late. Can we go back to the ones that shows the dashboard by geographical areas? I don't know if that was introduced. One question that we had, like I guess maybe 2 or 3 meetings ago, is that in this one, is it possible to layer this different information so that by a geography I can understand, race and ethnicity, language, age, or sex orientation? Is that possible or not yet?
No, it's not really possible. I worked with my data team on that, and they were concerned because of the volume of the data that it would essentially kind of break the system and break the way that they have the data structured. If there's a specific facility that wants to see that data, then that's something that we can give them in a different way. But on the dashboard itself, to be able to play with it on the dashboard, it doesn't work with the way they've structured the dashboards.
No, okay. So maybe as they think for any new implementation, maybe, one beauty of these data mining type of tools is be able to see data from multiple perspectives. And this one is very likely the most important, but something that they can think about it if they do any other implementation or any other way. With that, I just want to again thank you, Dr. Davis, for your leadership, and please send our very heartfelt thanks to all the members of the committee for their hard work and the impressive work that they have done. Now I just want to find out any old business that we should cover. Any new business? That being said, there is no further discussion. Meeting is adjourned. Thank you, everybody. Have a wonderful day. And now we go to the Finance Committee.
This meeting is no longer being recorded.
What a pleasure to listen to all of you.